Now the last class, the specimen, just for 3 minutes.
Last session, this viscera or specimen. I am not discussing any theoretical part of the disease involved here. Just to how to present a specimen, how to answer the question in specimen table. Bas. Okay. Now, there are some general consideration about presenting a specimen. If a specimen, it is here in the table. So first, rotate it in anatomical position, as if you, posterior side towards yourself, and anterior side towards examiner. Before that, you have to see the specimen. First, identify the mother organ. What is the organ? Here it is larynx. Here it is maxilla. It is the mother organ. Then identify the other structures attached with this specimen. What are the other structures? Never tilt a specimen. Never tilt a jar of the specimen. Okay. If you want to see it, just rotate it and observe carefully. Then mother organ, attached organ, and then what is the specimen? It is a not a post-mortem specimen. It is a post-operative specimen. Patient may be alive till now. It is post-operative specimen. So if I have to describe this specimen, it is a specimen of larynx along with other structure attached to it. What are the other structure attached to it? Upper part of the trachea first. Then see the anterior surface. Anterior surface টা দেখা যাচ্ছে না, guard হয়ে গেছে। It is expected to have one lobe of thyroid, as it is a larynx specimen. It is expected to have one lobe of thyroid. Which lobe of thyroid? The disease site. So it is a specimen of larynx along with trachea and here right lobe of thyroid, obtained by which operation? Total laryngectomy. Obtained by total laryngectomy operation. Then come to the pathology. Sewing. Obtained by total laryngectomy. Sewing. What is the pathology here? Again, very difficult to focus a specimen in a camera. There is a mass lesion in the right side of the larynx, in the right hemilarynx. So you have to know the subdivisions of the larynx to specify the specific anatomical position of the mass. Now what is the type of mass? Generally we describe ulcer or proliferative, but not here. Ulcer cannot be commented in a specimen. It can only be commented in a living body, ulcer. So it is a mass or proliferative mass only. Better to utter only mass. A mass involving. There is a niche. What is that? That is vestibule. Vestibule of the larynx. So upper part of it, the upper fold is false vocal cord and lower fold is true vocal cord. So the mass is involved. Involving supraglottis as well as glottis. So it is a transglottic mass. So mass involving supraglottis and glottis in right side. So probable diagnosis is very difficult to show. If you want, you can come here.
Actually, when you have to come, first see the mass. Actually, you have to put it in your hand, rotate in the anatomical position,
There is just a swelling.
extension
Okay.
of the mass. When you are describing the pathology, extension from anterior to posterior, superior to inferior, try to describe. Nobody is going to ask you if it is not accurate. Nobody is judging you. But you are trying to describe the mass, that is most important. It is from the anterior
The
commissure.
description process must be accurate.
That is important. You are trying to describe the pathology, that is more important.
Probably it is submucosal growth. Probably it is submucosal growth, and there is an extension.
Extension from anterior commissure. You try to see from the anterior commissure is going beyond the whole of the vocal cord on the right side, extending beyond the adenoid. And you can see the mass.
Medial wall of the pyriform fossa is probably involved.
There is a mass also extending outside the pyriform fossa, and it up to the thyroid cartilage. You can see up to the thyroid cartilage there is a gross mass which is absent in the opposite side. If you see the opposite side, there is not a gross enlargement and that particular pyriform fossa. Okay.
So in this specimen, it is very difficult to say whether it is laryngeal, primarily laryngeal growth extending into the pyriform fossa, or it is a pyriform fossa growth extending into the larynx. You have to present in this elaboration. We have to present it with this elaboration. That is, sir, it is very difficult to say whether it is primarily laryngeal growth or primarily hypopharyngeal growth. But mass is involving medial part of the pyriform fossa as well as right hemilarynx. So next question is, what is the staging? If it is hypopharyngeal growth extending into the larynx, then what is the stage? For staging clinically, vocal cord mobility is very important. So in many times it is difficult to say whether it is T2 or T3. But it is, I am saying it is T3. Why? I am saying it T3 because it is a back calculation. The treatment of T2 is not total laryngectomy. Treatment of T2 is not total laryngectomy. So it must be T3 as the total laryngectomy is performed. Okay, then the theoretical discussion about the mainly staging and its treatment approach.
Now, one thing when you are describing specimen, first thing the surgery is done, what surgery is done. Second thing is it's a specimen, try to describe the normal structures. You can see it like this one. This is a maxillectomy specimen, but this is not a total maxillectomy specimen. It is a infrastructural maxillectomy. Okay, and this is if you see closely, what we get in the total maxillary specimen is the floor of the orbit. We get the floor of part of the floor orbit. We cannot see the maxillary sinus through a proper total maxillectomy specimen. Okay, so here we can see the floor is absent. So we can say this is not a total maxillectomy specimen. So for that, if you come to a conclusion that it is not a total maxillectomy specimen, so you have to describe the normal structures first. Then go to the lesion or the pathology. Then describe the pathology. You don't have to mention this is a specimen of total maxillectomy or this is a specimen of infrastructural maxillectomy. This is not necessary, but just to describe the structures, normal structure and the pathology is very important. Then you come to the conclusions what type of maxillectomy you are saying. Okay?
So it is a specimen of maxilla along with
alveolus.
Alveolar process is part of maxilla. Teeth. What are the teeth? What are the teeth present here? You have to describe it.
Obviously, you have to say the which side is involvement. It is a right-sided maxillary specimen or left-sided maxillectomy specimen.
If it is a bilateral structure, you have to determine the side. Here there is no question, but here is right or left. So right maxilla along with the teeth. What are the teeth? You have to see and you have to mention it.
You can have also a bilateral maxillectomy specimen also. You can get that also. If the mass is cross the midline, then you have to do the opposite side maxilla involving the nerve. So in some case situation, you can get the specimen which is a bilateral maxillectomy specimen. Okay?
And here the superior wall of the maxilla is open. It may be to show the it may be the postoperative opening to show the mass in a specimen, or it is an infrastructure maxillectomy. And showing a
the point I want to identify, this is the prominent one. You can see the most prominent bony structure here, and if you put it, this side is anterior, towards you is the posterior. Okay, so anteriorly there is a prominence, bony prominence is a frontal process of maxilla. You can see that, And in the behind, rather laterally, there is a zygomatic process where we cut the maxilla. And if you see from the above, you can see the mass mainly in the posterior medial part of the wall of the maxilla, and it's actually dividing and coming out into the, you can say it is in the infratemporal fossa. Okay? So this is the mass description. It can vary, but first of all, if you can see the mass, if a total maxillary specimen, I'm saying again, you cannot see what's inside the maxilla, you can see what if extending outside. Only then the mass you can describe, otherwise it's not possible to describe.
Most common extension is in a maxillary here in the medial wall, in the nasal cavity. So if the mass is extended within the nasal cavity, you can see the mass in outside the maxilla as well as within the maxilla. It is better to say, as a diagnosis, it is silonasal carcinoma. I cannot be sure that whether it is a maxillary shear coming into the nasal cavity or it is a nasal cavity shear going inside the maxilla. So it is a silonasal shear, but here there is no medial extension. Medial wall is clear. Medial wall is clear here.
In infrastructural maxillectomy, do we cut the inferior turbinate or not?
No.
Yes or no?
What are the wall of the maxilla involved? It is if it is opened. What are the wall of the maxilla involved by the mass? You have to check it, you have to mention it. Accordingly, your staging will be determined.
The next, everything, if you have described the specimen, no, then everything will be from the theory part. And the most common question in the previous class also says that what are the cards of the maxillectomy? That is the most important. And the card differs in a total maxillectomy and infrathyroidistic maxillectomy. The cards are different. So I think somebody has told from you that the first cut is in the frontal process of maxilla. I think I am right. Somebody has told me, yeah. So is it true? Is it true? First cut is what? Why the periodic of the cut is very important. I mean, why we can just do the pterygoid cut first? Why cannot do the pterygoid cut first? What is the first cut? Ideally, textbook, what do we call it? Orbital cut is the first cut, okay? Inferior orbital fissure, including the inferior orbital fissure, in total maxillectomy, is the first cut. And the last cut is a pterygoid one because bleeding. Yes, actually we are afraid of bleeding. One thing we are afraid of is the bleeding. So what are the most important vessels we can injure in the maxillectomy? What is the most troublesome bleeding? Internal maxillary artery. Okay, if we cut the maxillary artery, when we cut the pterygoid, if we cut that fast, the bleeding will so much that we cannot handle the thing. So last thing we want to do is that we open up the pterygoid. If there is a bleeding, we can control that. That is why the cut is important, and the proper way of cutting. I mean, the first one what we have to cut, the second which we have to cut, the last one what we have to cut, that is very important. Okay, these are the theoretical parts. You can.
There is a theoretical question. What will be your approach for the nasal bone? What will you do for nasal bone? Will it be removed? What can you do? You have to do a osteotomy, just like rhinoplasty, reflected with the skin flap. And after the operation, you have to replace it. And you have to do another procedure before going to the bone cut. That is, you have to do a DCR. Open DCR, actually.
When we cut the frontal process of maxilla, we also cut the lacrimal sac, and we open the lacrimal process basically. In that situation, we open up the lacrimal duct, I mean a sac or duct, whatever we get in the point, and we have to just ligate that thing with the soft tissue there, so that it does not get stenosis. That is the most important steps when you do the maxillectomy or lateral linotomy procedure, whatever you're doing. And the vessels which is important in that situation is, what are the most common vessels cause the bleeding at that point? Yes, anterior ethmoidal artery. Anterior ethmoidal artery.
The position of the anterior and posterior ethmoid artery, you have to do the first cut below the arteries.
And what is the importance of frontoethmoidal suture? These are the most common questions asked in whenever maxillectomy specimens will be there.
So there are two important. One is vascular important, one is neurological important. Vascular importance is what you have said. And neurological importance, it is the junction between the nasal cavity and cranial cavity.
We don't
if you
go
go
over
above
the
it,
frontoethmoidal
you may enter the cranial
suture.
cavity,
If
enter
we
cranial
do that, we can injure the cribriform plate and the CSF blind will happen. So in that situation, always the cut will be below the frontoethmoidal suture. And when we are accessing the suture, the first thing we will encounter is an anteroethmoidal artery. We have to ligate the anteroethmoidal artery in a proper total axillectomy, but we don't require to ligate the posterior artery. Okay? We can come down before that. The cut should come down before that. That is the thing.
And what instrument is used for which cut? What instrument is used for which cut of the maxillectomy? First cut, osteotomy, Gaussian osteotomy. Second cut, it's palatal, Jiggly-Shaw. And third, zygomatic. It may be depend upon the surgeon. Some surgeon use Jiggly-Shaw also. Some surgeon use osteotomy. Some surgeon use Fisher bar. And last one that is pterygoid.
For the terminate, fourth one is the inferior terminate. Then
You have to use one instrument. Which instrument? Not ordinary gouge. It is Besto's osteotomy.
This is basically
Slightly anterior
carved
curve in
osteotomy.
the tip.
Carved osteotomy. And in that situation,
It
when
is
you
not actually osteotomy, last one. It is actually separation. There is no bone cut, last one actually.
we put the osteotomy there, we down fractures the maxilla. Down fracture, that is important. Down fracture the maxilla will come out. So specimen, you don't have to bother about the specimen, just whatever you get the specimen, you just try to describe. No, nobody will going to question you if it is not properly described. You're trying to describe.
Diagnosis is wrong or right, it is not a
Nobody
factor in a
asking.
specimen.
If
Not a factor in
the
a specimen.
problem is if you don't identify it's the right-sided maxillectomy specimen with the left-sided one, then the questions appears. Otherwise, you are describing thing and the lesion you are describing is not proper, nobody is going to ask you. Then the questions will come from the laryngectomy steps also, from the laryngectomy specimen, total laryngectomy specimen, or the cuts from the maxillectomy specimen. These are the most common specimens given to your exam. Alternately, somebody will get total laryngectomy specimen or somebody will get total maxillectomy specimen. That's all, okay?
If you have any specific question
Any
about the
questions
specimen,
regarding?